Great to be here. I'm going to take a few minutes and maybe set the stage for maybe interpreting some of the context of what we're experiencing right now and the political dynamic and how the policy dynamic will touch upon all the work we do and what we have to do next. You know, I tend to think that we make significant incremental changes to healthcare, or try to, about once a decade. And if you go back, the period of time are littered with both successes and challenges, but I would say increasingly there's more and more that we lose than we gain. But if you go back, you know, you include in the 1960s, of course, is probably the most significant advance we made in the healthcare system with the passage of Medicare Medicaid in 1965. So what was particularly remarkable about that? What was the most important thing that happened for Medicare and Medicaid? Well, for me, it's this. In 1965, 1 out of every 3 seniors in the country was living below the poverty level, which I find very hard to imagine in this country. 1 out of 3 seniors. Today, that's about 1 in 12. It's about 8%. Enormous progress, due in large part to the fact that we know that health insecurity is the big driver of financial insecurity. And so that was an enormous progress in the 60s. You skip ahead a bit to the 90s. The big initiative was driven by then First Lady Clinton. And that was not a successful effort, but there were a couple things that we learned out of that effort. One of them was that as much as we might want to significantly change things about the healthcare system we don't like, there's a whole bunch of people that actually have something secure that they like. Employer-based insurance, veterans-based care, what have you, and they don't want to give that up for a brand new system. And I think that's the primary reason why she wasn't able to be successful. The other thing that happened was, as a response to Hillary Care, conservative-leaning think tanks came up with this idea called an insurance exchange and an individual mandate. So this was a conservative response to Hillary Care. So obviously hold that thought a couple decades, right? In the 2000s, I think we probably had some, I'd call it more incremental and marginal progress early with Medicare Part D and with Medicare Advantage. And then, of course, in 2009, the Affordable Care Act. Okay, so what happened with the Affordable Care Act? Well, let's talk about the positives and the negatives, okay? The positives, I think I would sum up this way. We changed the compact with the American citizen, with the American resident, of what it means to get access to care in the following way. We said, doesn't matter your income, doesn't matter your health status, doesn't matter your health history, you should have access to affordable health coverage. That's the primary thing we changed. And it's an enormous change. It requires everybody to do things differently, a set of trade-offs for everybody involved. And we have largely, by and large, accomplished that. We haven't fully accomplished it, but we've largely accomplished it. We also cut the uninsured rate in half, and we've made progress on a number of other fronts that we're just beginning on. But what didn't happen? What was left undone? Because I would say, with anything of that significance, our expectation should be that we get about 70% of the way there. And then we have an environment where we can continue to gain on it and make progress and have that level of bipartisan support. Well, one thing that didn't happen is the way that got done, for whatever reason, left the country very divided, or it left at least Washington very divided, and it didn't create the level of support needed when issues inevitably come up. That's an enormous lesson we need to take with us to the next places we go, because we simply can't afford to have our healthcare system shift election cycle by election cycle. The other, I think, thing that didn't happen was there's a significant inequity. We are at a place in healthcare where few of us can actually afford to buy healthcare on our own. There's no greater illustration of that and why that is than Libby's book, actually, which I would say is a tremendous gift to our understanding of what really goes on in the healthcare system, not what people think goes on or what should go on, but really happens. It's an enormous gift, so thank you for for that.
Thank you.
And what that tells us is we charge each other too much for health care. We just charge each other too much. Now, we do it for a variety of reasons. One of those reasons is we're addicted to the jobs in health care. 80% of the costs are labor costs and not the scientific drug costs. But we know this, right? If we go to an ER, if we get a prescription, we see those costs. Those costs are too high. And so what do? Well, most of us, the government helps us with that. If we are a veteran or in the military, or if we're a senior, or if we're low income, we have help with that. The government provides Medicare, Medicaid, or some other program, TRICARE. And now, if you're up to 400% of the poverty level, you also get a tax credit. And of course, if you're employed, your employer gets an enormous tax deduction to provide a health benefit. But what's left undone is people who make over 400%, i.e. the middle class, who buy insurance on their own. Those are the people that don't have that access. And they're the only people now left in the country who feel that cost. They feel the true cost of health care. It's revealed to them. So it's not necessarily simply that the ACA made health care more expensive for them. It's just that now that they're feeling that in a real way, much more so. So that's a challenge. And I think I'd add to that, even if you're a believer that free markets work, I think all of us probably believe that they work to some degree or another. You'd also believe that markets aren't perfect. Markets break. And particularly in rural America and other parts of the country where we don't have enough competition, particularly among hospitals, we have a challenge. Those things are exposed. So if we were thinking rationally, we would say, okay, the ACA, by the way, came in hundreds and hundreds of billions of dollars below budget. You would take some of that money, you'd invest it back to create subsidies for people above 400% of poverty level. Rates went up a little higher than we thought they would, in part because employers didn't move their employees into the exchanges, so the risk pool was a little smaller, so the federal government saved money. And we should have done some things like shoring up competition, the public option, or increasing subsidies. Things that I think are very tactical and very surgical, and we didn't do them. But I think the larger point here is we as much as we accomplished, we found ourselves in a place where the politics of healthcare became too overpowering and became a tool that divided us, which left us to the current debate that we've been having, which has been essentially all about one party trying to break down the commitments made by the other party. And so we're in a place now where we have a bunch of competing views about where we go next. And what I want to talk about for the next few minutes is how do we make sure that the debate we have next time around in the 2020s, when we do this again, that we do it right and that we come away with more of what we want. And I would tell you, thank God we only do this once every 10 years because it is exhausting, right? The country has other business to take care of. So when the energy comes back again, and normally it's the first year or so of a new president, but let's just say it's sometime in the mid-2020s. The question I think we should ask ourselves is, how do we do that next debate in a way that we come away with what we as Americans deserve? And I would put forward that there are 4 building blocks that I think we ought to be thinking about, and we ought to be working on them now so that we can actually do that. The first of those building blocks is, rather than trying to sell an idea or force a compromise in D.C. and from any one of the ideological platforms, whether it's single payer or whether it's on the other side, kind of block granting the entire healthcare system, let's instead invest the time with the American public to go out and understand how they think about the trade-offs involved in making sure we provide coverage to every single American, that people have a regular source of care, that people don't go bankrupt when they get sick, and really address this as a kitchen table issue. Because I think the goal ought to be to find a set of policies that 60 to 70% of the American public are willing to support. Because the way we'll get bipartisan support for a deal and stop the flip-flopping back and forth is if we can find a set of policies that 60 to 70% of the public support. We do that, in a very high likelihood, we will have a Congress that hews to that. If we don't, then I think we're in a different situation. So if Bernie Sanders believes that single payer is the way to go, that to me is the test it ought to take. Now, the good news is I think we'll have a number of other options in the meantime. We have a bill coming out shortly which creates a Medicaid buy-in option. We have a bill coming out that will have a 55 age buy-in to Medicare. We'll have a number of other options to consider. And that leads me to my second point. My second point is that we ought to spend the intervening period between now and then testing at a state level what policies work and what policies don't. So go back to the early 90s when there was a development of exchanges. If it wasn't for Romney Care, it wasn't for the implementation of exchanges in Massachusetts, there never would have been an ACA. There's no question about it. CBO wouldn't have known what to score. Policymakers wouldn't know how to develop it. But more importantly, we learn what works and we learn what doesn't work, and that allows us to do it better. So we have to actually go out and test some of these ideas and figure out the things that work. Otherwise, we're in what I like to call think tank fantasy camp. Okay? Think tank fantasy camp is a right-wing think tank who basically believes that the free market can solve all our problems. And by the way, the people that make up both sets of think tanks are largely people that have never lived in the real world, with all due respect to them, because I think we need their thinking. And in the left-wing think tank, don't believe that there's any unintended consequences from government control. And neither one of those is necessarily wrong, and neither one's necessarily right until we test it. So what we have to do is we need to take things like the Nevada experiment that almost passed, called sprinkle care, which I just love saying. That's actually the legislator's name is Sprinkle. For that reason alone, I think it's strongly worth considering. And we need to test these things out. The third thing that needs to happen, and is very much to the point of Libby's book, is we need to spend intervening period focused hard on costs. Now, in healthcare, generally speaking, if you're talking to a Democrat about health policy, they want to talk about how to cover more people. And if you're talking to a Republican, they won't want to talk about sustainability and cost and how do we make sure our system's affordable. And we can all do a better job listening to one another, because the truth is you can't do one without the other. You know, Democrats would be wise to understand that the reason we can't have the policies we want is because we just can't afford it. And I like to remind my friends who are in favor of single payer that if we had a constitutional amendment in favor of single payer tomorrow, we wouldn't know how to implement it. We wouldn't know how to serve people. We wouldn't know how to afford it. So that's important. But I would also remind my friends on the right that just taking a scalpel and cutting doesn't make care better. It just cuts. So we need to focus on those areas where we really have opportunities to make sure we are controlling costs, have those difficult conversations, and make real progress in some of those areas, and I'm sure we'll talk about some of them today. Fourth area that we need to focus on, in my view, is we need to unlock the innovation potential of our country in a different way around healthcare. If we count on the public sector or government to do all of this, we're really missing, I think, one of our key strengths as a country. So, to my mind, we think about innovation in healthcare the wrong way. We think about innovation in healthcare technology very much like we think about fads and capabilities. So whether it's investing this year in AI or last year in digital or the year before in interoperability, we're chasing capabilities and technologies. And I'll just be very blunt about it. Having run the Medicare and Medicaid program, looking at the fiscal constraints, our problem as a country isn't the 60-year-old jogger with 2 Fitbits who records their time to their runs. They don't need more devices to do that. Our problem is the woman who lives 2 bus stops away from her dialysis center. And if she misses one of those buses, she is going into kidney failure, and she may die, but she's certainly going to be spending a long time in the ICU needlessly. So we have to redirect our investment, in my view, towards how we care for vulnerable populations, how we care for low access populations, how we provide the services around the needs that people have, that by the time they get to the healthcare system, it's too late for the healthcare system to do anything about it. I'm talking about the things we all know about. I'm talking about behavioral health, I'm talking about housing, I'm talking about adverse child events, I'm talking about nutrition interventions, I'm talking about all the kinds of things that everyone else, the rest of the world, invests in, so they don't have to invest in healthcare, and we don't. So those are the four things that I think are critical building blocks. Again, find a set of policies that 60 to 70% of the country can support. Sit down at the kitchen table, go outside in, don't go inside out. Invest in that. Secondly, start working in states, create the sets of experiments and opportunities that we can then test and see if we can use at a national level. Third, focus on cost and real cost areas. And then fourth, start to move our innovation and investment as a country towards caring for the hardest to treat low access populations. And I think if we start doing those things now, in recognition of the fact that sometime in the next decade, we're going to have an opportunity to come back and ask the question again, can we deliver ourselves more? Can we, in fact, create a set of policies that not only we can implement, but people across the country are invested in and believe that they can make succeed? I think we'll be a lot happier in taking the lessons from those years.